There we go. Okay. So this is also kind of a preview of fall CE. You're going to get this much more in depth during the actual CE, but we wanted to present it and discuss it here for a couple specific reasons. So we have had a whole lot of conversations and looking into how we're doing sedation and restraint, right? It's become a big topic nationally, big topic for EMS, certainly an area of liability. And we want to make sure that we are doing everything we can to protect our providers as well as our patients here. So we've changed a couple things on the COGS, we've changed a couple things on the approach. And partly I wanted to discuss it with you all first because you're kind of the subject matter experts in the department on these types of patients. And I want to make sure that you guys don't see any things that we're missing or have any additional suggestions or ideas or stuff like that. But the other, I guess we'll jump to the punchline. One of the things that we're changing is crews should now be requesting any single responder unit plus a fire apparatus anytime they think they need to sedate somebody. Okay. And I'm jumping ahead to, I don't know, slide 11 or something like that. The reason for that is we want as many hands and as many eyes as possible to keep eyes on the patient and make sure that we're getting them on the monitor quickly, actually watching the monitor, right? Paying attention to their vital signs, watching their airway, all that kind of stuff. So fire is there because they're the closest unit, right? We have plenty of times when we're out of medic units. If I'm asking for another medic unit, I'm going to be waiting 20 minutes and I don't have time for that in these kinds of situations. Fire is close. They're all PL2s. They should all be able to put on monitors and tell me when the oxygen is below 90% and that kind of thing, right? And then we're also requesting a single responder unit. You guys are probably going to be closer and more available. And we're kind of trying to like shift a little bit of like, okay, what do we send district commanders to? What are we sending DMOs to? What are we sending our other single responder units to? And these types of patients seem like a really good resource for you guys to be jumping on. Okay. So we'll back up a little bit. So that's the punchline. That's the why of we're having this conversation. Now let's back up and do a little bit of the actual lecture. So it's been a big topic nationally, like I said. A whole bunch of cases that have drawn a lot of attention. ACEP has come out with a statement on this. NAEMSP has come out with a statement on this. There's been all kinds of new policies. Obviously, we renamed it for various reasons. When we looked at our own numbers internally, so we've done a lot of deep dive into how are we handling these patients here in Austin. And what we found is some interesting, oh, awesome. Thank you very much. Well, it's a Mac, so let's see.
There it is, yes.
Oh, there we go. Okay, awesome. All right, I'm gonna put this thing down. To be fair, it's my computer that he's messing with, so I don't know. Okay, so some things that we've seen. Interestingly, so these are all Austin numbers. These are not national numbers. This is just our numbers here in Austin. Overall, we're sedating a lot less people than we used to, okay? And I think part of that is actually credit to y'all. For your involvement in some of this stuff. And part of it is probably just more awareness and thoughtfulness on the part of our crews, probably a little more hesitation in sedating. So I will say that overall, I think these numbers are good. But one of the things that we're going to be talking about with the crews is if your patient needs to be sedated, it is actually the safest and most appropriate thing that you can do for your patient is to sedate them. Okay. There are some patients who need to be sedated. Like in order to save their life, they need to be sedated. The patient who is in true hyperactive, agitated delirium, I think I screwed that name up already. I still can't keep it straight. Former excited delirium. The patient who is in true former excited delirium, disease formerly known as excited delirium, their body is not going to keep up much longer. Their catecholamines are already going crazy. Their heart rate's as fast as it can go. Their blood pressure is up. Their temperature is up. Their respiratory rate is up. And the safest thing that you can do for them is sedate them and take all of that offline. Okay. Now, it is risky for us because all of a sudden you're responsible for all the stuff that patient was doing. But if you're going to make the decision to sedate a patient, like, let's do it all the way. Okay. Because what we generally find, and this actually applies, I think, in my experience to all kinds of procedures, right? I've seen it in the ER, like with a med student or a resident who's like, thinks they want to do a central line, but they're not 100% sure. And they're like kind of dilly-dallying around it. That's when you screw things up. Okay. If you think the patient needs whatever procedure, airway management, sedation, whatever, like go ahead and like be fully committed. Okay. Because it's when we try and do this like piecemeal that we miss important pieces. All right, I'm getting ahead of myself. So sedation for severe agitation, our numbers overall have generally gone down. We are finding that we are doing a much better job of documenting RAS. I think that's a funny graph because it was flatlined for many years because we didn't require RAS documentation. So it was 0. Now we're doing better. Anyway, we're doing a better job of documenting RAS. There is still ongoing conversation about whether or not that is the most appropriate tool to be evaluating these patients with. It's an ICU standard. It's not a field EMS standard. So there will be more conversation during actual CE about like, is that the best way to actually document this? These are some interesting numbers. So overall, we are doing better at least documenting end-tidal CO2. It's still kind of like all over the place. That's going to be a big push, is we have to be getting that end-tidal CO2. That's actually probably one of your most sensitive vital signs in any patient, right? So we know, for example, in our trauma patients, one of the reasons that end-tidal CO2 by itself is a criteria for administering blood is because there is a massive piece of literature out there looking at, I forget how many hundreds of thousands of patients, showing that drop in end-tidal was the earliest predictor and the best predictor of need for massive transfusion or risk of death. Okay, so end-tidal CO2 is an incredibly sensitive vital sign and very helpful for monitoring these patients. Watching for a drop in it is a good sign that your patient's about to code, for example. It's a challenge specifically in these patients, though, because it is also the most invasive vital sign, right? So pulse ox goes on the finger, blood pressure cuff goes on the arm. End-tidal is in your face, okay? So understandably, like it takes a little bit longer to get the end-tidal on. I'm okay with that. But we really do need to be pushing for getting end-tidal on these patients. We're going to talk about documentation in a second here. One of the other changes that we've made is giving you a whole list of here are all the things that should be documented on these patients. And one of them is document your vital sign monitoring. And if there is any delay, document why there was a delay, right? So it's perfectly acceptable if you need to wait 7, 8, 9 minutes to put end-tidal on the patient if they're still grabbing at stuff and still getting agitated. You just need to document that that's why there was that delay, okay, in order to protect yourself. Okay, so complication rates from ketamine. We've had a handful of folks who require airway management of some sort. All of them ended up with BVM. A couple people ended up intubated. A couple people ended up with an iGel. We've had, I want to say, 2 cardiac arrests in the last several months post-sedation. The challenge is always, okay, well, did they code because of the sedation or did they code because of whatever else they had going on that caused the agitation that ended up with the sedation that ended in the cardiac arrest? Aha! So Doho asked how much of that is related to stacking meds. It's almost like I gave cue cards out to the audience. So, well, true. So that is exactly the problem that we identified. Is almost all of these, both with airway issues and with cardiac arrest, were because of multiple different medications. So another big change that we're making is if the patient is a RAS of 4, if they are the most agitated, they're getting ketamine. All the ketamine, only ketamine. Okay, we're not doing the Versed and droperidol and maybe like some of this and some of that kind of thing. It is because, so remember, politically, initially there was kind of a pull away from ketamine because that was what was getting all the headlines. Well, what we can show now with our numbers is actually ketamine is the safest drug for these patients, which is actually what we've always known. And it kind of got swayed because of politics and stuff. And we think that we can make a strong case to come back and say, no, actually, ketamine is the best thing that we can do for these patients, and only ketamine, right? Less agitated patients, we're going to do Versed and droperidol, and there will be some time hacks as far as how long you should wait and that kind of thing. But a full-on, checked out of reality, cannot control them, RAS of 4 kind of patient gets ketamine, and that's it. So, okay, verbal de-escalation. So looking a little bit for your input on this one, this is education that's going to go to the field in terms of how to try and de-escalate these patients. And I realize it's not all of the same stuff that you guys are doing, but we're trying to come up with some like general rememberable stuff for the field to kind of talk them through how do you talk to patients, right? Give them a crash course in how to be a chipper until a chipper shows up on scene. And I mean, this is a lot of the kind of stuff that you do, right? Support, let's work on this together, acknowledging whatever their feelings and emotions might be, validating it, naming the emotions, right? I need to figure out how to have a class on how not to be an asshole. I don't know if we'll be able to cover that in CE. So maybe we'll get Kim to do a just-in-time training that can go out to the field, right? Like talking about the concept that sometimes you're the one, and I mean, we talked about this yesterday, right? Sometimes you're the one riling them up. And sometimes just like taking a step back and letting things calm down for a second, right? By the way, when we talk about, you should have all these extra people on scene for a sedation, that we realize that's not always going to be practical either, right? Sometimes you show up and there's 10 cops on top of a person and you need to get in there and get ketamine on board right now. And get the cops off of the person, right? We are trying to encourage calm to maybe keep an eye out for these and start sending resources. We're going to be educating the field. If they think that this is what they're going to roll up on based on CAD notes, call early and ask for resources. We did look specifically at the dispatch determinants on all of these calls that ended up with sedation because we were trying to figure out, like, is there a specific dispatch code that like routinely ends up with sedation? It's all over the place. It's not predictable. So we couldn't come up with anything where we're like, on these calls, we will automatically dispatch a chipper or a fire unit or whatever. So it's going to be a lot of education of call for resources early if you think that's what you're going to need. For y'all, I would say keep an eye out on some of these kinds of calls, right? Click on the notes, read the CAD text. If it looks like it might be something like this, try and start heading that way just in case. But we also realize like the field crews are going to be dealing with a lot of stuff of this kind of stuff by themselves without any additional resources for this first several minutes. So we're kind of trying to give them that crash course in how to be a chipper. Okay. Sure. Yes. Yeah. 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 And this again kind of goes to what we're going to be talking about in the team. Oh, yeah. So Jeff was asking, should we just be jumping these calls if we see it in the CAD notes? Yes, please. So this kind of again goes back to that concept of pruning that we're going to talk about more during the team meeting, which is we've kind of spread out and started doing all of this stuff, and we're kind of losing focus of where we could be making a bigger impact within the 911 system. So we're going to cut back on some of these other things to try and encourage more involvement like on this kind of stuff. Okay. I think there's a lot of areas where integrated services could be making a huge difference within the 911 service and for our fellow colleagues that we're kind of not having a lot of attention to right now because we're doing all this other stuff. We're going to cut back on some of that stuff and help focus more on how do I serve my fellow medics and how do I serve our patients in more of the acute 911 setting. And I think this is an excellent example of that, is if you see these kinds of calls, you think this might be what's going down, yes, absolutely, please jump this call and get over there and help. Now, the other thing that's going to require some discernment on your part when you show up on scene, if the crew has decided that the patient needs to be sedated, I don't necessarily want to get into like any kind of like a power struggle, right? Like I don't want you guys showing up on scene saying, I'm a chipper, I know how to handle mentally unstable patients. We do not need to sedate this person. I can talk them off a ledge or whatever, right? The problem is there might be a couple times where that is actually the case, okay? So it is going to require a tremendous amount of skill and discernment and insight and wisdom and thoughtfulness and all the things, right, on y'all's part to be able to figure out, like, do I think that this is actually a patient that doesn't need to be sedated and I can step in and like help prevent that? Or am I just here to help support, right? Again, when a patient is sedated, as long as we are properly monitoring them and taking care of their airway and breathing and all the rest of that kind of stuff, it's actually a very safe procedure, right? The problem comes when not everybody's on board, right? And we're doing this kind of half-heartedly, not all the way in. So that, I will tell you from now, that is going to be your struggle, okay? Is figuring out, when do I jump on board and help the crew out? And when do I say, hey, I think maybe we can handle this a different way? My concern is if you all keep showing up and saying, no, we don't need to do whatever it was that you were planning to do, nobody's going to like seeing you on scene, right? So balance that in there also. Justin.
It is weird, but your PL5 or PL6 is a higher credential provider and all over our head, and a clinical specialist get overridden by a captain on. Well, right, like there's a power dynamic.
So there's all kinds of, right. So this is one of the other, yeah. So Justin was pointing out there's all kinds of power dynamics here, right? There's the PL5 versus PL6. There's the clinical specialist versus captain. There's the field medic versus integrated services. Like there's all kinds of things here, right? The overall mission is do the right thing for the patient, right? And all of those different capabilities should be viewed as resources. Just like when I open my airway bag, I have an OPA and an MPA and an iGel and a BVM and a direct laryngoscopy and a video laryngoscopy and a crike and a whatever, right? Like I have all these tools in the toolbox here at Austin EMS, and there's not a whole lot of guidance on how to do this because nobody else is doing this yet, right? Like there's no other system that basically has a hospital out in the field, okay? Because that's what we're dealing with here. So when I'm in the hospital, I have all kinds of resources at my disposal, right? I can call a surgeon, I can call an orthopedic surgeon, I can call an internal medicine doc, I can call a dermatologist, they're not going to show up. I can call, right? Like I think I've gotten derm to show up exactly one time in the emergency department, and that was back when I worked at Herman in Houston, right? So anyway, but like I have all of these resources when I'm working in the hospital, and I can pick and choose and like use whatever I want. Out here in the field, traditionally EMS has just been, I have a paramedic and an ambulance, and we can go to the hospital, right? And here in Austin, we have all of these other resources, and it's a lot of figuring out like, okay, how do I balance all of that? So I'm not going to give a whole lot of direction on it is always the captain over the clinical specialist or the PL, right? Like the COGS do say the highest credential, right? So a PL6 trumps a PL5, who trumps a PL3. But it needs to be a team conversation, right? Like, yeah, I'm a PL6 or I'm a doc, but even when I show up on scene, like we don't always do immediately whatever the doc says. Like it's a conversation, right? I may say, hey, what do you think about this? Or I think we should do this. And sometimes the crew pushes back and they're like, actually, no, I don't think we should do that because of XYZ, right? That conversation should happen. By the way, that's part of why we encourage the crews to call us by the docs by our first name out in the field rather than Dr. Abraham, because I want to encourage that open like flow of conversation, right? Travis.
So I was just gonna say that in the context of the power dynamics, PL5, PL6, if it's still cordial, a really good solution, and I know this up personally, is just, hey, how about we call med control?
Yeah.
Let's see what I think about this.
Totally.
And
Yeah.
then, at that point, the PL6, who technically out credentials me, has now been trumped by
the doc, right? Yeah. So, and that's always an option too, right? Depending on like how quickly the scene is moving and all that kind of stuff is, hey, call online med control and see what online med control thinks about this. Now, if you have 10 cops on top of a person and, vital signs are already unstable, don't call a doc, like make a decision. Okay. But yes, in those kinds of situations.
I think also one of the things that I've seen us be most useful on is when there's a plan that already has momentum, people can get locked into it. And multiple times, I know chippers have shown up on scene when people are about to stay and gone, hey guys, he's unresponsive. We no longer need to sedate this person.
Yeah.
So that's like one of the most effective. It's not confrontational. It's a simple UI from a patient going, you don't need to follow this plan.
And that is actually the biggest thing that we're looking for the single responder unit on, right? So whether it's a chipper, C4, PRU, PA, district commander, whatever, the biggest role for that single responder unit is to kind of take a step back and look at the whole scene and see like what are we missing, right? So I don't want you guys getting deep in pulling up the meds or administering the meds or putting the patient on the monitor or any of that kind of stuff. If you need to, if you're the only other set of hands, sure, absolutely. Like jump in, all hands on deck. But if there's enough other people there, the role of the single responder unit is to step back and look at the overall scene and make sure we're doing all the things, right? Make sure the patient is breathing, make sure we're getting them on the monitor, make sure, we're communicating appropriately, like that kind of stuff. Okay. A couple other tips for success. For the field crews, we're going to talk a lot about this one-on-one interaction, right? So a challenge, a lot of these patients are already hearing multiple voices. They're already getting a lot of perceived stimuli because of whatever else they have going on. If I have 5 different medics yelling at the person, I'm trying to help you calm down, whatever, right? Like they're not going to follow that. So we're going to tell them, hey, I need one person who's going to be the spokesperson with the patient, and all communication flows through that one person, right? To try and remove like as much extra stimuli as we can. Making sure the providers are safe, making sure the patients are safe, being respectful, setting limits, all that kind of stuff, right? Setting limits, there you go. Okay, so there's your meds. We're not going to talk about them a whole lot here. Remember, we're going to switch to just ketamine for our RAS of 4+, and then droperidol and Versed are your options for your less agitated patients. Okay, following sedation, click, 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 right, go back. Shoot. I think I hit it once too many times. Wait, I'll get it right this time. There we go. Last. Well, no, so apparently they all show up once you hit the button once. I thought you had to like click through. Okay. So obviously once the patient is sedated, we know there's a whole bunch of different things that could be causing this agitation. Let's figure out if we're dealing with any of those things also, right? Okay, so again, this is where you guys come in and are important. We want to get the patient on the monitoring equipment as quickly as possible, recognizing end-tidal CO2 is the most invasive, so I can save that for last. But my goal is still, I need all that stuff on within 5 minutes, right? Like this patient can spiral down quickly, depending if they were already about to stop breathing and now I've got ketamine on board, plus whatever other drugs they may have. Like I need to be keeping an eye on that airway pretty quickly, okay? So the goal is get the patient on sedation as quickly as, or on monitoring as quickly as possible. All right, here's the fun part. If you scan that QR code, the new cogs show up. So you can take a look at those. I did not put this presentation together because this is way too much technology for me. We also know that Travis did not put this presentation together.
Melissa Miller in the front.
Yes, it was Melissa. So I checked, these all work. And there's a couple cogs. So that one I think is the behavioral cog. This one, we also separated out hyperactive delirium from the rest of the behavioral type stuff in an effort to really focus on, hey, we are handling these patients a little bit differently. We're using only ketamine. They're a little bit higher risk, all that kind of stuff.
Assuming we did actually get it,
Mm-hmm.
we still have the option of calling it.
Yeah. So if you have hit your max dose on whatever medication or your max time, or you have not yet reached your time limit on other medications for the lower agitations, but you think the patient still needs something, I would call med control at that point. I realize that that kind of slows things down a little bit. That's a little bit intentional. But because what we have found, especially reviewing some of these negative cases, is the patient was actually like about to calm down, and then you gave them another dose of medications, and now they have too much, and now they've gone apneic, right? So, and Melissa will talk a lot more about the pharmacology and like time of onset and how long it lasts and all the rest of that kind of stuff. These medications, like ketamine acts the fastest, which is why it is actually the safest for these extremely agitated patients. But remember, like the pharmacology takes a couple minutes to work, especially depending on what route it was administered and all that kind of stuff. I'm going to wait for a couple more cameras. The one that I actually really want you to take a look at, she didn't label them, is either this one or the next one. We'll find out. So there's a checklist. It's broken down into 4 boxes. I think it's like red, yellow, green, orange, or something like that. Is that this one? Oh, okay, great. Well, let's try this one. Try that one. In the behavioral one or in the excited? Yeah, so we took it out of the behavioral one because that one's going to be just Versed or droperidol. We're using ketamine only on the hyperactive delirium.
It did RASA 4.
It has a RAS plus 4 and then doesn't have treatment.
Oh, excellent. Thanks for pointing that out. I'll let Iggy know. See, this is why we were doing like the draft presentation first, and then we'll do the real thing for the cruise. Yeah.
I know it's very hard to know beforehand, but if I'm in I think this guy only needs a small amount of percent, where I think that I need to have a either here, fire here, or
Good question. Yeah. Yeah, good question. So Brendan was asking basically like at what level do I need the cavalry, right? If I'm just giving somebody a whiff of Versed because I want them to calm down a little bit and like stop breathing 50 times a minute, do I need the single responder unit and fire and all the rest of that kind of stuff? And the answer is no, not necessarily. It's provider discretion, right? Yeah, like you don't have to call everybody if I'm just giving somebody like one of Versed to calm them down a little bit so we can ride to the hospital safely, you know? But usually, like, again, these are all tools in the toolbox, right? So what we're going to be reminding the crews is, hey, like if you think you might need extra hands or something, like I think it's this one, here's the list of all the things that need to happen, right? Here's all the sedation and monitoring and treatment and documentation, everything that needs to happen. And if you don't think you have enough resources for that, ask for some more people, okay? We're trying to build that concept in a lot of other areas also, right? So for example, on our sick pediatric calls, we are still working on getting COM to send 2 ambulances and 2 district commanders on any pediatric cardiac arrest or super sick pediatric patient, okay? We're trying to get people into the mindset of, we're doing a lot of medicine here. We're doing some really advanced stuff. I don't know what he's doing. We're doing some really advanced stuff here. It is bizarre that we're asking one person in the back of an ambulance all by themselves to do all this kind of stuff. Like, ask for additional resources if you think you need it. The other, actually, where I thought your question was going to go is, what if I start with something low because I think that's all they need, and then we end up more agitated and I'm having to give other medications? Is that okay? Yeah, like the story changes. It's fine.
This is just spitballing, but in my experience, it feels like there's 2 versions of sedation. There is the we are stable enough for me to titrate.
Mhm.
There is the I can't titrate because I don't have time.
Right.
It feels like more the I can't titrate because I don't have time is the color.
Yes.
And
Yes.
stable enough to titrate, I can.
Yes. Yeah. And different people are going to have different interpretations of, are we stable enough to titrate, or am I going like all out?
I know the situations that we've had that, I feel like sometimes take the call where
Oh, yes. Yes. So we are trying to come up with what did Travis say? Safe word. So we're still, if anybody has suggestions, yes, we like, so fire will say, I have a box alarm, and a box alarm gets a certain number of whatever, however many red trucks, right? We don't have a word yet. If you have a suggestion, we are all ears for a agitation alert, sedation package. I don't know. Send me the cavalry. All right, Nazi patrol on their way.
Code blue, code black, code red.
So we could, right? Like following how they do it in the hospital, actually. Code purple. No, Dr. Pyro left. We could just say code purple, because that's in hospitals most of the time. Code purple is an agitated patient or a violent patient. I don't know. We're still working on that part. If anybody has good suggestions, let me know. Okay, so trying to wrap up here. So this one should be like the checklist of all the things that need to be done, right? So the concept there is, as long as all this stuff gets done, whether you do it with 1 person or 5 people, I don't care. That's up to you. But as more people show up on scene, maybe hand that to fire and say, hey, can you make sure that we're doing all of the things in that first box, right? Or all of the things in the second box, something like that. This is also for y'all as the single responder unit to pull this up and kind of use it as you take a step back and look at the overall scene. Is all the stuff in this box getting done, right? Iggy spent a lot of time on this particular checklist. So he's pretty passionate about checklists and making them actually useful, right? Like having enough stuff and not too much stuff and all that. I think we hit it right with this checklist in terms of like, if you are doing all the stuff on the checklist, like you're good. These are all the priorities. These are all the things that need to happen.
I would actually urge against a code word.
Okay.
Or safety word, whatever, because in something that we're finding in the field, when people start asking for, they start labeling things. So
Yeah.
Especially when it comes to code 3 PD response.
Yeah.
We've started seeing sometimes people use whatever they think is the code word.
And it's not.
And we have an abundance of officers responding.
Yeah.
Calls where they probably weren't needed. I think actually allowing the medic or somebody on scene to pause, think for a second to go, I need my single responder, I need fire department, so you can actually hear that gives them a moment to think,
yeah,
what do I actually need?
Yeah.
Do I need everybody coming like sirens, or do I just need somebody to be here to help?
So that's an interesting argument, because you're right. We have pushed on other stuff to ask specifically for the resource that you need, right? So don't ask for a commander, say I need a blood resource, right? Don't ask for a commander, say I need a ventilator, that kind of thing, and let COM send you whatever the most appropriate. So Yeah, you're right. It's telling them, hey, ask for a single responder unit and a fire truck.
I feel like when you're fighting somebody, like you have something from stress though, that may not be as effective.
It takes a little longer.
I need emergency sedation response.
Yeah, but if you're fighting somebody.
Well, not fighting, I'm sorry. If we have somebody that is RASP plus 4, it can be hard to have the wherewithal to be able to specifically tell every responder that you need. So RASP plus 4 could be as simple as I need emergency sedation response. And if you are not at that point, it could be I need this, I need this, I need this. And that-
I'm going to argue over the fact that I've had multiple, but you can't.
You're right. So the blood resource is the sedation resource that gets you. Yeah. Yeah. And maybe I mean, we also push for plain language, right? So maybe keeping it as simple as I need a sedation response, rather than trying to come up with some code, whatever. That also helps us avoid like right? Like, I don't want to start labeling like, this guy's a code purple, right? Like, no, this guy is still a person. He's getting a code purple response, but right, Kenny? Yeah. 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 Sure. Yeah. So I think the restraint checklist mostly got rolled into the new. Shoot me a quick text about that, and I'll follow up. I think the intention was to replace the one with the other. Yeah. So if there's specific pieces that are not on there that you think should be there, let me know. Yeah. Jeff. Yeah. So their education will come in the spring. Yep. Yeah. 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 So yes. So this has been a hot topic. So the question of not handcuffing to the stretcher. So this has been a hot topic of conversation, and like the chiefs of EMS and police are working this out. So the problem is the stretcher is considered part of the vehicle. It is crash tested. It is firmly attached to the vehicle. It is part of the vehicle. And you cannot have a patient attached to the vehicle in case of a crash or something like that. So yeah. So that is an ongoing conversation with law enforcement, where we are trying to get them away from that, and to more safe and appropriate, restraints. So it's a no from us. Uh-huh. Yeah. So you can handcuff them. They just need to be handcuffed to themselves, not. Yeah. Right. So PD should handcuff themselves to the stretcher. Right. So the. Yeah. Okay. So so the underlying problem is that law enforcement needs to be a little bit more responsible on some stuff. We probably shouldn't be like trying to manipulate them into doing that. I realize that is a highly effective technique. Maybe not. Yes. Sure. No, I don't think they're going to fight with that. I think the guys are asking, well, if I handcuff them to anything, like as long as I have handcuffs in the back of the ambulance, the police is going to have to come like retrieve their handcuffs from the hospital.
Told they were doing things that they did not. I arrived at the hospital, no law enforcement, forced suspects to be in my ambulance and go to the hospital.
Yeah.
Their will. I had no reason.
So there's some bigger systemic issues on the law enforcement side, right? That are like actively being looked at and attempting to be addressed. We probably shouldn't be trying to manipulate the system. And I would argue, I think those are mostly one-offs. Great. Well, you're a one-off.
Now, here's a question I'd like to work on.
Yeah.
Law enforcement is under the impression that MOU is not required for consent. They're under review, you can take them by.
It's called Texas Administrative Code.
Yes, and that is one thing I have had with CIP, et cetera, multiple times. Love the code, but if you don't have an MOU, you can't use. Verify that and then
Yeah.
remind them.
Yeah.
I actually just got an email from one of them going, I don't think we need an MOU.
Okay. Yeah. Let's follow up on that one. Okay. All right. Key takeaways. Hyperactive, that's what it is. Hyperactive delirium with severe agitation. Okay, RASM 4+. Ketamine is the drug. All right. We have also gotten rid of the whole guess their weight thing because it turns out there's plenty of literature saying medics do a bad job of guessing how big or small a patient is, right? So we don't want you being up on the stand saying, all right, well, the actual scale shows that this person weighed however many kilograms. Why did you say they weighed this much and dose them inappropriately? Right. So again, don't want to put the medics in that position. So we are saying a small person gets 200 milligrams, a large person gets 400 milligrams. Every single person in this room is considered a large person. What? Okay, so small person gets 200, big person gets 400, the end. Redosing strategies, their goal RAS is low. Sedation care package, we kind of talked about that. It's in the new checklist. We kind of talked about like, do we have provider 1 does this, provider 2 does this, provider 3 does that? We said, no, like we need a lead clinician and we need like these additional resources. And as long as all the stuff gets done, again, this is us attempting not to get you guys hung up by saying, well, provider 1 was supposed to do this thing and provider 2 was supposed to do this, but provider 2 ended up doing that and provider 1 ended up doing this. Like, I don't want you guys getting in trouble for that. So we said, we're just going to say, here's all the things that need to get done. You guys can figure out who does what. Okay. And again, as the single responder unit on scene, you're supposed to be more of the heads up, more of the scene oversight, make sure that all the pieces are getting done and not necessarily getting like deep in the weeds hands on unless you're the only other person there. Right. Okay. And then this is one of the things that I feel much better about is we have a list of all the things that need to be covered in the documentation. Okay. Because that is the other place that we see medics getting in trouble across the country is they actually did the right thing. It just wasn't documented properly. And of course, a lawyer is going to tear that apart, right? So here's a list of all the things that you actually need to document. And as long as you're documenting this stuff, doing it and documenting it, like that should cover a lot of the issues that we've seen pop up in legal cases. So you have to have some kind of assessment before you sedate the patient. You have to, like, it has to be your own decision based on this criteria, right? We can't have you being like, I sedated them because law enforcement said to. Documenting when the restraints were applied, any delays in, monitoring, all that kind of stuff. As long as you cover all of this, like that should keep you much safer from a legal perspective. Yes. No, hard would be considered handcuffs. We are looking at different soft restraints. So yeah. Safety, Roger Patterson and Garrett, I forget his last name, have been in all of these or a lot of these conversations. Also, we've identified that injury to providers is a big issue, especially in these cases. And some of it is related to the restraints. So we're looking at like restraints that are easier to put on, a little bit more reliable, that kind of stuff. So So this should be mostly in the document, in the checklist. Yeah, it's the bottom right box on the checklist.
It says notify supervisor.
Okay.
Yeah, so let's talk about that. Okay, so, and again, like all of this is geared at, we are trying to keep our medics safe, right? And out of legal trouble. One of the things that we know from documentation in general, is. Med control, stand back.
400 of ketamine.
Hey, what's up?
I guess.
Yeah. That's fine. That's fine. If he's gonna keep an eye on him, he's familiar with it. He knows when to call us back. Yeah. Yeah. Yeah, I'm good with that. Cool. Thanks. Bye. Okay, so we're back. Sorry, guys. Also covering backup med control today. So we know that when we are documenting stuff, we tend to fill in blanks in our own mind, right? Like we think that the documentation is appropriate because we know exactly what happened and we're thinking that the documentation covers it. These are such high risk cases, like the chance of them getting reviewed in some case or another, in some legal fashion or another, whether because the person is getting prosecuted or somebody wants to prosecute us, or right, like this documentation has to be solid. So we are going to ask somebody else who is not involved in the call to read over the documentation. This is not a time to critique your patient care management. This is not a time to critique your decision making, anything like that. This is supposed to be, here's the checklist of what's supposed to be documented. Here's the narrative. Check, 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 check. Yep, you covered it. Okay. This narrative describes the scene and covers the necessary details. All right. Now, we are having conversations about, okay, how do we, like, we only have 4 DMOs. Do we need more DMOs? Do we need to train the commanders to do more? Like, right. Like, we are also having bigger conversations about more opportunities for that kind of like actual clinical feedback. But this very specifically is, here's the checklist, here's the narrative, do they match up? Okay. And again, that is to make sure that you have said all the stuff that you need to say. By the way, that's a good habit in general for any kind of high risk call, is have enough self-awareness to say, I'm emotionally wound up about this, or I'm exhausted because it's, 30 minutes from the end of my 24-hour shift and I've been up all night, or this is just a super high risk call and there was a lot of moving parts here. Let me get somebody else to read my documentation. Okay. And in that case, I would say it's perfectly appropriate to call one of your commanders here, call up one of your fellow chippers and say, hey, can we meet up somewhere and you look at my ESO and tell me if the narrative makes sense. Okay. That's a good habit to get into in general.
We need to worry about QA/QI and
No. So I would say in this particular case, like as long as it is like one supervisor looking over your chart for that specific reason, I'm not super worried about it. Yeah. To me, that's no different from you're sitting around, at shift change the next morning. Hey, let me tell you about this crazy call I had. Right. And that's actually a perfectly appropriate place to have it also, is like, hey, fresh chipper coming on, exhausted chipper going off. Can you read this narrative real quick before we go and tell me if it makes sense? Right. That's no different from telling you about the call itself. Yep. 2 in the weeds. Moving on. No. Yeah. Once you lock it, you can't. Once you lock it, any changes are tracked. So, yeah. So this is, anyway. Yes.
But if you're sending it to a commander.
Yeah. So I don't know that everybody has that capability yet, although I think it's coming. That I think is one of the things that we are still, let me make a note to self.
I believe the commanders have access to that.
Who?
The command staff.
Command should already have access to this. This is, I need to double check with Iggy on like the logistics of this. I would say for right now, I would leave the chart unlocked. And we'll figure out a way to make sure that whoever else can see it and give feedback. Yeah. Yep. All right. Other questions, comments, thoughts? I think that's it. Oh, hang on. There's, wait, no. Sorry, I lied. There's 20. Oh, there's 19 slides. There's only 19 slides. And all right, well, it's not letting me show it. So there's 3 never events that we talk about. You should never transport a patient in the prone position. We know that. You should never transport patients handcuffed to the stretcher. And you should never administer sedating medications prior to a patient assessment. So that was one of the big things that hemmed up the medics in the Aurora case was it sure looked like they gave sedation because law enforcement said to, not because they had done their own independent assessment. Okay. That's it on the COG stuff. Any questions on sedations, restraints?
I just have a couple short suggestions on the de-escalation.
Okay, yeah, send those to me after. That'd be awesome. Jake. Legal. Next. So soft restraints can be cut off. They're actually a little more likely to actually tear in an accident. And they will still do some soft tissue damage, but like a handcuff and you get in an accident, like you will deglove that hand. And we would rather not do that. Yeah. Justin.
My last one, Roberto versus Ed.
They're both great. So I'm also trying not to steal all of Melissa's thunder from the actual CE. Like you're going to get all of this, like 2 hours of this when you get to actual CE. There are nuances to Versed versus droperidol, right? I like Versed when I'm not worried about a blood pressure, when I think I'm dealing with like an actual, like a sympathomimetic of some sort, right? Like they're high on meth, whatever, right? Versed does a good job of kind of calming that down. If I have any concerns about QT, even though it's been completely disproven, I still don't want to be like that one unfortunate case where we just happen to go sideways, right? So like I tend to err on Versed on that side. Droperidol I like because it's more of an antipsychotic. So the patient who is agitated because of more of like a psychosis kind of thing, I think the droperidol helps treat the underlying cause there as well as calming things down. So I like droperidol better for that one. Droperidol is also a little bit more hemodynamically stable. So Sarah.
Yeah, so this is both operational questions, but also related. I was told to stage on a call.
Mhm.
Some guy who was very irate, he was suicidal. He was threatening, "You're gonna shoot me or I'm gonna kill myself." He was probably just by the call text.
Okay.
So we were told to stage, and I told Thomas, "What? About 10 cop cars on scene. I felt pretty confident I'm fine." So I did go on scene, and I was able to de-escalate the guy. But I had 3 reasons going on scene bypassing the stage option was because one, he's suicidal. Sometimes they don't react well to cops, so I figured maybe I could escalate it. The second reason was he was combative enough where they would have to take him down by force. And so to me, that was like, we're going to be staging until they feel like that they do. Right? So how long is it going to be on top of this guy?
Yeah.
This guy, that kind of stuff. And if I'm there already on scene, then I can make that quick decision on let's get him.
Let's sedate him quickly. Yeah.
Before he gets more injury. Right?
Yeah.
And the third one is also because if they're going to go fisticuffs with this guy, then police officers are also being there. So I'm also there for them as well. And when I did go on scene, they were all excited. They were like, "Oh."
Yeah. So the operational folks in the room can cut me off if I'm wrong here. I would say in my mind, to some extent, the decision on staging is a little bit up to your discretion, right? Depending on how you're interpreting stuff on scene, right? Half the time the cops just forgot to clear us in. Like they're all there. They're waiting for us. I thought you called EMS. No, I thought you called EMS, right? I thought you said the scene was clear. No, I thought you said the scene was clear, right? So, right. Right. So half the time it's just everybody forgot, right? Like it's up to you to read the situation and say, oh, I think in this case, it's safe to go in, for all those reasons, realizing it's your decision, just like a whole bunch of other operational decisions on scene. So here's where I will plant another little concept. On the clinical side, we have really pushed the concept of just culture and failure is an option, right? Like we're going to give you a bunch of knowledge and training on the clinical side, We realize that you're humans operating in a human system, and sometimes you're going to screw up, and that's okay. We're not going to yank your patch. We're not going to decredential you immediately. Like we may put you on a training plan. We may like give you some opportunities for improvement and stuff. But the goal is to improve you as a provider. Okay. We're trying to start pushing that on the operational side as well. Okay. And this is coming from almost the top down. One step down. But this concept of on the operational side, we want to encourage that also, right? Where we want to encourage you to make decisions, take responsibility for your decisions, make the best decision that you can, have a reason to back it up. And hey, if that wasn't the right decision, great, we'll talk about it. We'll do some re-education. Maybe we'll do some things differently next time, but like, that's not the end of the world, right? So kind of have that in the back of your mind too on operational stuff is we are giving you, we hope, a lot of good tools, a lot of good support. You have fantastic leadership here. We are all looking for you to be successful. So whether on the clinical side or the operational side, if you make a decision that maybe wasn't the greatest decision, great. We'll re-educate as needed. We'll offer areas for improvement as needed, but like it's a learning opportunity, right? It's this whole anti-fragile concept that we keep talking about, where as long as I like stay in my safe little box and never do anything outside of the rules and always do exactly what somebody else tells me to do, great. Like I probably won't get broken, but also like I will never become anything stronger or better as a result of that, right? So pushing this anti-fragile concept both clinically and operationally. Hey guys, like go out there, try new stuff, especially in this crazy like integrated services division, right? Try new stuff, see what happens. You're gonna fail at some of it. Like some of it is gonna, like you're gonna do it wrong. It's gonna break. It's gonna be screwed up. That's fine. Great. We all learned. Don't do that. Moving on, right? Maybe it'll get called the Thornton policy. I don't know. Everybody needs a policy name.
Understanding of the policy is that Tom is required to give you safety instructions.
Yeah.
So they get a little uptight about it, and then they'll get written up if they don't get the safety instructions.
Yeah.
And they require you to acknowledge them. The decision that actually stays is. That's why it's here.
Yeah. Yeah, I would agree with that. Like comm is going to do the best they can to protect you with the very limited information that they have over the radio. It is up to you once you are boots on the ground to make the best decision with the information you have.
Two medical legal questions.
Yeah.
First, just clarification after the last discussion time came out. If we have a patient that is suicidal but otherwise has capacity for transport.
Yes.
If
If they are
capacity, but they are suicidal.
if they're suicidal, that removes their capacity.
I thought
Yeah.
that you required.
Oh, yes, you do. Sorry, I missed the question. Oh, if you don't have a if you don't have a POED, then you can't.
It seemed like you don't have law enforcement there. They're not under POED. You can just transport them voluntarily regardless.
No, you have to have a POED. Yeah, if they have capacity and they're refusing, and yeah, then you have to have a POED. Yeah.
The follow-up is when they're on a POED, they're valid, are they eligible?
Yes. Yes.
That's all I have.
Yes.
They did a good job.
All right. Yes.
Throughout your presentation, you referred to the shipper.
I said all of integrated services, any single responder unit. Yes. Any single responder unit. Yeah. PRU, chipper, PA, doc, commander, chief. Yeah. Anybody who's driving around under their own power. Yes. Okay. I'm going to close
Have to respond.
that.
We're,
Oh, I left the call. Bye. Okay. Do we have anything else that we need to cover on the MI6 stuff? Or are we moving on to